first I want to go over some of the history of organ transplants. So the first organ transplant was actually performed in 1954, and it was between two twins, and the one twin needed a kidney. So, and then 1967, it was the first successful heart transplant. And in the 1980s, they had advancement in immunosuppressant drugs, which were actually the drugs that you had to keep taking after you got the transplant to help the transplant stay and work correctly. They also had advancements in blood typing, which helped with matching. And then there was also a system created called UNOS, which helps finding donors with patients that need the transplant. So then now today, there have been thousands of transplants that occur yearly, but the demand of transplants far exceeds the actual supply of them. So for current statistics, 103,000 men, women, and children are actually on the national transplant waiting list. 17 people die each day waiting for an organ, and 48,000 transplants were performed in 2024, and this is actually, all this information is from HRSA, and every 8 minutes another person is added to the transplant waiting list, and this figure actually shows the number of patients on the waiting list by organ in 2024, and as you can see, the kidney is far more needed than any other organ, which I think is actually pretty interesting, since kidney is like the only organ you can actually donate without actually having to die. So for our presentation, we wanted to focus it about a case study, and our case study was about a boy named JM. He was brought to the US from Mexico at 1 year old. He was undocumented, but he was eligible for CHIP, which is an insurance, which we'll talk about later. And he was diagnosed at the age of 16 with end-stage renal disease, which means he needed a kidney transplant. The mother was actually a perfect living donor match who he could get her one kidney from to help save his life. So the ethical problem in this case study was that the transplant was actually denied by the Chicago hospital due to insurance coverage that would expire in 2 years. So he would not have lifelong medication affordable to him. The policy overruled medical readiness despite transplant ethics, which says that transplants are focused more on the need than financial situation. So the CHIP insurance policy is actually, this is what JM had, and it stands for Children's Health Insurance Program. And it's like a state and federal program. It was created in the late 1900s, and it helps provide insurance for uninsured children with too high of an income to apply for Medicaid. So it's like in the middle of a Medicaid and a regular insurance, but too low for private insurance. You have to be eligible for it through age, income, and your status. So not everyone can actually apply to get CHIP. And one of the requirements changes is CHIP can actually be revoked or expire anytime. So CHIP actually coverages in all states, and it coverages for like wellness exams, doctor visits, office visits, prescriptions you get from the pharmacy, inpatient, outpatient, hospital care, lab work and imaging, dental visits, vision care, and emergency care. So for JM's treatments, the average price for his kidney transplant in the US, which is where this was taking place, is $300,000 to $500,000. And this includes the transplant, after transplant care, and all the medicines, which was what his insurance was not covering. And to the right, you can actually see some of the costs in some countries of how much it costs to have a kidney transplant. And you can see in the US it's about 450,000, and the next highest is actually Germany, which is 80,000. And just between those two, like, that's a very large amount difference. So the ethical question we really came up with from this case study is the cost to save a life worth more than actually the human's life itself? So some additional statements I wanted to say is how the data system of Johnson, it demonstrated that patients without private insurance were actually less likely to refer to the assessment to get a kidney transplant. And insurance status and personal ability to pay significantly affects access to transplantation in the United States, which is what transplant tries to put onto people, that it doesn't really matter about your financial status, but from this case you can actually see that in these additional cases you can actually see that it has been a problem in some places. So our argument for JM is he had a perfect living donor match. His mom, she didn't have to die, and it was just a perfect match overall for JM to get a kidney and save his life. He was young and healthy, and he was like a very strong candidate for success. And he was denied because of his future insurance and medical need, and not because of his medical need, but because his CHIP coverage would not cover the immunosuppressant drugs. The transplant is actually cheaper long-term than compared to dialysis, which he would have to be on if he did not get the kidney transplant. So an argument against the patient is there are limited organs. We know that the need for organs is much higher than how many people actually donate. So they want to give the organs to those who guarantee follow-up care to have better odds with the transplant actually working. There is a risk of the transplant failure without the proper medications and post-op care. And if there's no insurance, there's no way to afford like the lifelong anti-rejection meds. And organs should go to where long-term success is most likely. So my personal opinion is supporting JM's transplant because JM had a perfect living donor match from his mom who was willing to give up her kidney. And organ transplant should focus on medical need and fairness and not just about the ability to pay for the transplant and after drugs that he would need. And I think that saving a life should be the top priority and not financial concerns. And here are my references.